All right, welcome back to The Explainer. Today, we're diving into what is honestly a notoriously dense but absolutely fascinating area of pharmacology, anticholinergic drugs. We are going to explore exactly how we can molecularly hijack the human nervous system to save lives. We'll be breaking down the specific drugs, their incredible clinical uses, and of course, those critical must-know dosages. Here's our blueprint for today. We'll kick things off with blocking the muscarinic receptors, move into the physiological effects on the body, look closely at our prototype drug, atropine, cover the key synthetic drugs, and finally wrap up with toxicity and some highly memorable mnemonics. So, let's get right to it. Section 1. Blocking the muscarinic receptors, the foundational blueprint. Okay, so the absolute key phrase you've got to understand right out of the gate is competitive antagonists. These drugs, which you'll often hear called anti-muscarinics, are essentially engaging in a high-stakes game of molecular musical chairs. They sit down in the muscarinic receptors, and they completely block the neurotransmitter acetylcholine from sitting down and doing its normal job. And when you block acetylcholine, you're effectively turning down the volume on the body's entire parasympathetic nervous system, the rest and digest system. This one foundational concept really changes everything we know about how the body runs itself on autopilot. To really see why these drugs have such a massive whole-body impact, you kind of have to look at the receptor map. M1 receptors, they govern the brain and your stomach acid. M2 receptors are heavily concentrated in the heart, where they normally work to slow things down. And M3 receptors are basically everywhere else. We're talking smooth muscles and secretory glands. So when an anticholinergic drug enters the bloodstream, it's not just hitting one single target. It's sweeping through this entire systemic network of M1 through M5 receptors. Moving right along to Section 2, effects on the body, from eyes to sweat glands. So how does this actually play out in a patient? Well, it directly connects back to that receptor map. In the eye, blocking that M3 receptor literally paralyzes the sphincter muscle that leads to mydriasis, which is massive pupil dilation, and cycloplegia, meaning you temporarily can't focus your eyes. This is the exact deliberate mechanism ophthalmologists use to perform a proper fundus exam. Now, in the heart, blocking the M2 receptor essentially takes the brakes off the heart rate, causing tachycardia. But there is a very tricky, fascinating clinical pearl here. At really low doses, our prototype drug atropine actually causes a brief, paradoxical slowing of the heart rate. And the systemic blockade just keeps going. Up in the lungs, blocking M3 causes the airways to wildly dilate and dry up, which is an absolutely life-saving mechanism if we're talking about COPD and asthma. Down in the gut and the bladder, everything slows down and relaxes. This brilliantly reduces things like urinary urgency. But we have to talk about a critical warning here. Blocking the sweat glands stops the body from being able to cool itself. In children particularly, this can rapidly lead to a severe, potentially life-threatening hyperthermia that is famously known as atropine fever. Which brings us perfectly to Section 3, atropine, the prototype drug. Atropine isn't just some modern laboratory invention. It's actually a natural alkaloid derived straight from the Atropa belladonna plant. Yep, the deadly nightshade. It acts as a non-selective competitive antagonist, just boldly blocking M1, M2, and M3 receptors without any prejudice. Because of this really broad, aggressive action, it is heavily relied upon in medicine. It's used as a pre-anesthetic medication to keep a patient's airways bone dry during surgery. It triggers mydriasis in ophthalmology, and it acts as a powerful antispasmodic to stop the pain of intestinal colic. Now, this is where the pharmacology gets incredibly critical, literally life-saving. The single most important clinical use of atropine is as a fast-acting antidote for organophosphate poisoning. For this, you need to push 2 to 5 milligrams IV, and you repeat that dose until you see clear physical signs of atropinization, things like dilated pupils and a dry mouth. Alternatively, if you have a patient crashing in the ER with severe symptomatic bradycardia, your standard rescue dose is 0.5 to 1 milligram IV to get that heart rate back up. It's honestly fascinating how the old saying, "the dose makes the poison," applies here. We see a very clear dose-dependent reaction in the central nervous system. At low doses, atropine just gives you a bit of mild sedation. But push that dose higher and it crosses the blood-brain barrier with aggressive force. High doses result in severe agitation, terrifying visual hallucinations, and full-blown delirium. And because we understand those exact mechanisms, the absolute contraindications are going to make perfect logical sense. You absolutely cannot give this to a patient with angle closure glaucoma. Dilating the pupil physically crowds the drainage angle and dangerously spikes intraocular pressure. You can't give it to a man with benign prostatic hyperplasia because relaxing that bladder will throw him straight into acute urinary retention. And naturally, a drug that paralyzes the gut is incredibly dangerous for someone with a paralytic ileus, just as a drug that speeds up the heart is lethal in tachyarrhythmias. All right, Section 4, Key Synthetic Anticholinergic Drugs, the Specialized Squad. If atropine is sort of a blunt sledgehammer, you can think of these synthetics as highly specialized scalpels, chemically tweaked to target specific organs. Need to stop severe motion sickness? Scopolamine is the absolute drug of choice. Want to open the airways in COPD without all the systemic side effects? Use ipratropium. Doing a quick eye exam? Tropicamide is preferred just because it's short-acting. For an overactive bladder, you'd prescribe oxybutynin. And to manage the tremors and rigidity we see in Parkinsonism, we rely heavily on trihexyphenidone. The clinical logic behind these chemical tweaks is just brilliant. Take ipratropium, for example. It's inhaled directly into the lungs and has very minimal systemic absorption, which means you get that crucial bronchodilation without the awful dry mouth and urinary retention. Now, for severe COPD, we step up to tiotropium. This binds to the receptors for over 24 hours, making it totally perfect for a once-daily maintenance therapy. Meanwhile, looking at the CNS side, scopolamine crosses the blood-brain barrier far more easily than atropine. That causes profound sedation and amnesia, which is highly useful when prepping a patient for surgery or if they're about to go on a really rough boat ride. All right, final stretch, Section 5, Toxicity and Memorable Mnemonics. So, when a patient takes way too much of these drugs, they present with an unforgettable clinical picture called anticholinergic syndrome. It's beautifully captured by a historic mnemonic. Blind as a bat translates to massive mydriasis, preventing them from focusing. Dry as a bone means all exocrine gland secretions have completely stopped. Hot as a hair flags the dangerous hyperthermia from a total inability to sweat. Red as a beet points to compensatory cutaneous vasodilation as the body desperately tries to dump heat. And finally, mad as a hatter confirms the drug has crossed into the brain, causing acute severe delirium. Now, for a slightly blunter, more visceral way to remember those uncomfortable peripheral side effects, there is a secondary phrase that gets thrown around a lot in med school. Can't see represents the mydriasis and blurry vision. Can't pee translates directly to acute urinary retention because that bladder smooth muscle is completely relaxed. Can't spit is the severely dry mouth caused by the total blockade of the salivary glands, and can't shit means GI motility has basically ground to a halt, causing severe constipation. But what if we flip the script? What happens when there's way too much acetylcholine in the body? Say, a farmer exposed to toxic organophosphate pesticides. Well, we get the dumbbell syndrome, uncontrollable diarrhea, urination, meiosis, which is pinpoint pupils, severe bronchospasm, emesis, lacrimation, and massive salivation. The patient is essentially drowning in their own secretions. And this is exactly when we push those high doses of atropine to aggressively block the receptors and stop that massive parasympathetic overdrive. But wait, what happens if the pendulum swings too far the other way and someone is accidentally pushed into severe atropine poisoning? Step 1 is administering the direct antidote, physostigmine. This specific drug is chosen because, unlike others in its class, it easily crosses the blood-brain barrier to reverse that terrifying central nervous system delirium. Step 2 is active, aggressive cooling to stop the hyperthermia. And Step 3 is rigorous supportive care until the toxicity clears from their system. Okay, let's lock all this in with a quick, rapid-fire revision of the highest yield data. Atropine is our broad-spectrum prototype, and we push it at 2 to 5 milligrams IV for organophosphate poisoning. We reach for scopolamine for motion sickness. Ipratropium and the longer-acting tiotropium dilate airways in COPD and asthma. We use tropicamide for a quick eye exam, and we can calm an overactive bladder with oxybutynin. Before we go, I want to leave you with a bit of a provocative clinical puzzle to think about. We just learned that pushing 2 to 5 milligrams of IV atropine will save a patient poisoned by organophosphates by fixing all those muscarinic symptoms. But acetylcholine also acts on nicotinic receptors, which are what control our skeletal muscles. Since atropine does absolutely nothing to nicotinic receptors, the patient will still be paralyzed. So what is the secondary drug you must push to save their muscle function? Think on that one. I hope you enjoyed the deep dive today, and thank you so much for joining me on this explainer. Keep learning, keep exploring, and we'll see you next time.